Okay, I'm so pleased to introduce Dr. Stephen Thielke, who has been really the foundation for our ADRD series each year. Dr. Thielke is a professor in the Department of Psychiatry and Behavioral Sciences at the UW School of Medicine and a geriatric psychiatrist and health services researcher at UW. He conducts research about dementia medications, depression and pain in older adults, and the use of monitoring technologies in healthcare. And today, he's going to talk with us today about the whole person in dementia. Welcome, Dr. Thielke.
Thanks a lot, Barb. I'm thrilled to be here again as part of this very important series. As you will have noticed from the schedule, the key topics get covered on several occasions. So I'm going to try to present a big overview, but if I don't go into much detail about something, I assume it will be in the remainder of the series. And also you don't need to worry about getting all the details the first time. Instead, what I wanted to do was to set the frame for the whole series by bringing attention to what I consider to be a much more important part of dementia care, which is considering the whole person rather than just the brain or the cells. And I think it will become clear as we talk what I mean by that. Barb mentioned HRSA. This is a nice set of dementia-related resources that you can have. Just go to that website or search for Hersa Dementia, and you can see what the modules are. They map pretty well onto the topics in our series. So I've been treating dementia and focusing on it for about 15 years. And the more I see, the less impressed I am by the science of dementia, by which I mean what is in the bottom part of the slide, kind of what's known about something clinically and on a cellular level, and in terms of the effects of medications. So kind of the way you would approach some other condition. If you wanted to become an expert in diabetes, for instance, you would first understand the pancreas and what insulin does and how people develop diabetes and the subtypes of diabetes, what the tests are, who gets the disease and what happens during the disease. And certainly you could focus on those issues in dementia, but I really think that misses the point. And the more I know about dementia, the more I appreciate that the right thing for dementia care really is not based in science. Instead, it's based on a personal understanding of where the patient is coming from and what their family is dealing with in other words, why the disease is a problem. And that's what leads you to do the right thing in your care of patients with dementia. It's not knowing exactly what plaques or tangles are made of. So I put another way, if you had a Nobel Prize in how dementia works on a cellular level, it may take you nowhere for providing the right kind of care to people who have dementia. I know this is a little bit of a vague concept, and we are going to get lost in a lot of the details in the middle of the talk, but I'm going to try to both introduce it now through a vignette and also come back to this theme at the end. Barb mentioned about questions that we'll have time at the end, but if something comes up and it's burning, especially if what I'm saying doesn't make sense, please just put it in the chat and I'll watch and see if anything appears. If I don't catch it, maybe put it there again, and we can always come back at the end.
And I'll be watching, Steve.
Okay, thanks, Barb. Yeah, so I want to start this on a very personal level and have you think about your own life. So imagine one of your parents develops memory problems, gets confused about their medical care, gets lost, a little bit paranoid, and has left the stove on. And I want you to think about what you would actually do in this situation. Like the set of actions that you would carry out. Would you, like move in with your parents if you don't live with them? Would you take them to the doctor to figure out what was going on? Would you immediately call your family members. I think everybody agrees that in this situation you would do something, but it's not clear exactly what everybody would do. And also it pushes the question of what your needs are at this point. So obviously it's a wide set of needs, but the most basic one being a way to make sure that your parent doesn't burn the house down or get into huge trouble. So you can see that this would suddenly create a whole new set of issues in your life that you probably have not thought of before unless you happen to face this scenario. And if you think about how medical care might be useful, I think everybody would recommend that your parent get some kind of medical assessment, but also it's pretty clear from most perspectives that medical care is probably not going to fix this problem. You're probably dealing with something that is going to continue into the future and is going to continue to have significant effects on your life. So if you think about the next scenario, which is a little bit more extreme, now let's say that your parent not only has some memory problems, but they need a lot of help with basic activities of daily living. They don't remember who you are, they can't feed themselves, they can't toilet themselves, and let's say you're the only person in the world available to care for them. Everybody else has written them off. And I want you to think about how this would affect your life. What would you do? Would you drop out of school or quit your job in order to take care of your parent full time? Would you say, boy, that's rough, but they're out of luck? Would you beg other family members to do it? If your parents had the means, would you spend all of your inheritance getting them care or placing them in a place where they could be taken care of? Here again, you don't have to think about it too hard to realize that this would cause a huge effect on your life, and it would be extremely challenging. And the needs here are pretty obvious, that you need someone to do these things for your parent. And it's either going to be you or somebody else, or they're going to be completely neglected. So pretty clear what the challenges are. And then in terms of medical care, I think here again, we all know that if somebody is this impaired, the likelihood that they are going to bounce back or can take care of themselves is very limited. So your problems at this stage really are not medical in nature. They are much more social and related to caregiving. So obviously this is an extreme case, and I'm going to try to point out some of the nuances in the difficulties with dementia in this talk. But I think it does help to give it some personal context if you realize that if you had a parent with dementia, it would change your life drastically. And you can contrast this to, say, a parent who had a new medical problem. If your parent gets cancer, you're going to be rallying around looking for the most effective treatment to support them. And obviously you'll be dealing with their social needs as well, but really your focus would be medical. Dementia is a very different focus. So I want to think now about a third scenario, which is a little bit different because you have to imagine living in a different world where you live in a multi-generational house. There's a lot of people around. People don't work outside of the home, and so there's always somebody there. And people don't have set work schedules. So, and in this case, your parent needs the same things as in the past scenario. I want you to think about what this would be like for you. Obviously, there's no single answer to this, but if you look around the world, non-industrialized countries do a lot better job of caring for elders with dementia than industrialized countries do, because people are around and they can accommodate someone who's not able to take care of themselves. So there'd be the same practical set of problems, but the needs would be addressed because there are more people to share the work. And also there are lower expectations of someone's independence as they get older. And medical care obviously is about the same, but the interesting observation is that around the world in non-industrialized countries, in a lot of them, they don't even have a category for dementia. It's understood that as people get older, They sometimes, have memory problems, or they might call it senility, but it's not medicalized in the same way that we do here, because people can accommodate the challenges that the individual faces. So when you see this in a very broad perspective, dementia is a problem because of socio-cultural reasons. It's not primarily a medical problem. It's a problem because people with dementia are no longer able to satisfy their role obligations, and other people have to adjust their lives in order to take care of things for them. So this is definitely some big social editorializing, but I really encourage you, as you're thinking about what dementia is, to remember that it's not mainly a medical problem. All right, so we'll come back to this theme at the end again, but I do want to dive into the more specifics of what dementia is, and the subtypes of dementia, and what happens during it. So there's 3 definitions that I want to look over. Each of them has advantages. They're all about the same thing, just a different focus. So the first is a significant chronic loss in memory and or mental functions involving structural damage. And what's important about these is what they rule out. So significant means that it's not just a subjective concern. You have to have actual functional consequences. I will say this about 8 more times. And if there's one thing you take away from this talk about dementia, it is that it requires functional effects. It's not just doing poorly on testing, and it's not just somebody having worries about their memory. Dementia has to be chronic. It's not something that happens quickly. If somebody has been okay, recently, and now they're really severely cognitively impaired, that really does not suggest dementia. It has to be a loss. So if somebody, for instance, had developmental delay and they always had significant cognitive problems throughout their lives, that would not be considered dementia either. It involves memory and or mental functions. It's not just memory. We'll be talking about this around some subtypes. And then finally, it's actual structural damage to the brain. This differentiates it from our other psychiatric conditions, which we assume involve neurotransmitters, put briefly. So it's not just brain chemicals, it's actually that your neurons are dying in dementia. All right, so another definition that's a little more technical but covers the same thing is that dementia is a progressive neurodegenerative condition with functional consequences. It's not a lifelong condition, it doesn't happen quickly, it's not a normal part of aging, and it's not insignificant. But it's not necessarily just memory related. Alzheimer's is one type of it, but it doesn't have to be that. You don't have to have any specific behavioral effects. You do have to have functional consequences, but you don't have to act out or be distressed. Age is not mentioned, but as we'll see, it clearly is related, and it's not necessarily a fatal condition, although it often is. All right, the third definition is based on DSM 5, which is the Psychiatry handbook on how to diagnose things. So Judy just asked a question there about blood tests. We'll be talking about that briefly. No. So we'll talk a little bit about ascertaining dementia, but as of now, there are no good tests to define dementia based on labs or even on imaging. Great question. So let me go back. So this is known as a major neurocognitive disorder. In DSM-5, they realized that dementia is kind of a pejorative term, and so they created this other category instead. It's basically the same things as the other 2 definitions. Once again, functional problems are necessary. And it lists the various domains of cognition there. You can see it's not just memory. There are subtypes of this. You specify whether it's possible or probable dementia, and you specify if it's with or without behavioral disturbance, such as psychosis or agitation. Here again, a reminder that you don't have to have behavioral disturbance. And the severity of the dementia is based on your functional status. That is how much help you need carrying out your activities of daily living. So yet again, the emphasis is really on functioning. So just to reiterate, if you don't have functional problems, technically you do not have dementia. And of course, if you have functional problems because of a back injury, that's different than dementia. It has to be functional problems related to cognition. So I think I've made that point enough times now, and I won't say it again. Given the description I made, you'd think it might be really easy to define when somebody is demented, but unfortunately, a lot of these findings occur in other conditions. The three most common, and you'll get a whole talk about this next for the next lecture, are the delirium and depression. And both of those can involve trouble carrying out activities and somebody who doesn't seem quite right, as well as some confusion, but they are differentiated both by how they happen, when they start, and what. Except to point out that this is an important set of breakpoints to separate out dementia from other conditions, and you'll be hearing lots more about them in the next talk by Dr. Trittschuh. All right, so I want to talk a little bit about how often dementia occurs, and this really is important to know as you're trying to decide if somebody has dementia, and also to think about dementia on a broad social scale. These are rough figures, but they're still pretty accurate. So about 1% of people at age 65 have dementia, 6 to 8 over age 65, and by the time you hit 80, it's 30. So you can see that goes up pretty quickly. And this is a visual representation of it based on 6 studies from different, I guess it's only 5 studies. One of them's two of them are one set of data. But so this is from 5 different areas around the world. And it suggests that when you look at the age breakdown, the prevalence of dementia is about the same. So the question up there about the frequency of dementia is a great one, and we're going to address it soon. Basically, these data have not changed over time. The age-specific risk of dementia is about the same as it has been, but with population shifts in the number of people in the population, the overall prevalence has changed. So anyways, the important part of this is that dementia, very rare at age 65, very common at age 90. And the rate is roughly exponential in a curve. So the biggest risk factor for dementia, hands down, no question, is age, and in particular, age over about 80. So if somebody gets dementia at 45, you got to ask much more carefully about what's going on. All right, now I'm gonna turn to the subtypes of dementia, and this is just a very brief reminder of the lobes of the brain. So the yellow lobe in front is the frontal lobe, the pink one on top is the parietal lobe, the purple one on the bottom is the temporal lobe, and the back blue one is the occipital lobe. The changes in dementia are mainly in the pink and the purple one, although you get changes all over. So those seem to be the most affected. There's one form of dementia, frontotemporal, that affects mainly the yellow lobe, the frontal lobe. None of them seem predominantly to affect the blue lobe. There is another type, Lewy Body dementia, that affects the entire brain without a lot of specificity in the areas. So don't spend a lot of time thinking about that. Just a reminder of the main lobes of the brain. The subtypes that we're going to talk about are listed here, and the point of this slide is that there is a lot of overlap in these conditions. There are some studies that suggest that the most common type of dementia is mixed Alzheimer's and vascular, which would be the overlap seen there. Other studies suggest that it's much more common to have Lewy body dementia mixed with Alzheimer's than just pure Lewy body dementia. So this is not exact by any means, but when you're thinking about these forms of dementia, it's not like they're totally separate categories and they're going to be differentiated. So when somebody has symptoms, you need to make sure that you're covering all the bases. The main types of dementia are here. Alzheimer's is the most common by far. It's about 70% of dementias. Vascular is much of the remainder. Lewy body is not insignificant. Frontotemporals, Lewy body, maybe 5 to 10%, depending on the study. Frontotemporal is about 1%. And then reversible dementias really are not, as we'll see, something that should even mainly be considered as dementia because they don't really fit that definition. If you think back that it has to be a progressive condition, if it's reversible, it's not really progressive. So we'll go over these in order, spending most of the time on Alzheimer's disease. So this is a picture of Alois Alzheimer on the left, and his first patient that he diagnosed with the disease that got named for him on the right. Her name was August Dieter. She was a patient in an asylum in 1906. And it's very interesting history if you look back to that time to see what it was that was filling asylums with people who have cognitive problems and needed to be hospitalized. The main cause was something known as paralytic dementia or general paresis of the insane, which is a pretty fancy way of saying neurosyphilis. So most of the people who we would now consider to be demented actually had syphilis and then had neurologic effects from it and required a lot of care. There was not that much Alzheimer's disease around then, for a reason that I'll explain shortly. But Alzheimer's brilliant recognition was that this patient, August Dieter, had a different set of symptoms. Her presentation was different than the people who had neurosyphilis, and he spent a lot of time figuring out clinically how she presented. And then when she died, he took slices of her brain, and instead of finding the effects of syphilis, like spirochetes, he found characteristic changes that he drew there, and that later were identified as being plaques and tangles. So when the underlying problem in the brain on a cellular level is plaques and tangles. The tangles are inside the cell. They're made of something called tau, that's a protein in the cell backbone, the cytoskeleton. The plaques are made of a misfolded amyloid protein. Both tau and amyloid are everywhere in your body, so it's not like they're some kind of foreign substance. They're just mixed up in how they're folded, and they're not supposed to be insoluble. They're supposed to be spread around and diffuse. And then when you get these problems involved in Alzheimer's, you end up with plaques that clump together and are no longer soluble. There's obviously a lot more science to it than that, but that's briefly what you see. So there's a specific way of cutting the amyloid precursor protein that's recognized as causing these insoluble plaques, and that result in the changes seen in dementia. This also makes it look like it's pretty easy, and all you'd have to do is go in and stop one of these processes and you would stop dementia. But despite more than 100 years of work, unfortunately, we are not there. The downstream effect of this is not that the plaques and tangles cause problems in and of themselves. Instead, the problem is that the neurons die. So this is a brain of somebody who has Alzheimer's. You can see on the bottom right, that's a brain of somebody without Alzheimer's. The image in the middle is somebody with dementia. And over time, you have had hundreds of millions of neurons die in the brain. And the plaques and tangles may or may not even be directly causative for that. There's some thought that they're more just a marker of your neurons dying rather than being a cause of them. I won't go into a lot of the detail there, but please don't think that plaques and tangles are the cause of Alzheimer's. Ultimately, the cause is that the neurons die and therefore don't work well. Don't also expect that you have to have considerable brain shrinkage to have clinical symptoms of Alzheimer's, or that neuroimaging would help you to find out who has Alzheimer's. Unfortunately, there's a lot of people who don't have Alzheimer's whose brains have shrunk, and you can't really tell on any exact basis who the patients are and who the people who don't have Alzheimer's are, simply based on neuroimaging. So that's just briefly to remind you of what's going on in the cellular level and then on a global brain level. On a patient level, what you see is specific problems with brain functioning, as you may expect. Alzheimer's disease requires some form of memory problem, especially short-term memory, and then other forms of difficulty, and all of these are functional effects. So somebody who can't produce speech, who can't carry out coordinated motor activities, who doesn't recognize things, or executive functioning, the simplest example is balancing a checkbook. So being able to reason through a process from beginning to end. And then you have to have functional consequences related to these changes in your cognition. And finally, Alzheimer's is a diagnosis of exclusion. So as I mentioned, there's no blood test, there's no specific imaging test that will definitely say it's Alzheimer's. So you need to consider if there is another cause of the condition. On the theme of functional impairment, obviously a patient is not the best way to ascertain this. If you ask them how they are, usually they'll say, I'm fine, I don't have any difficulties. And the vast majority of patients I saw over the years at the VA denied having any difficulties whatsoever, even as they had a lot of problems. So the best way to ascertain functional impairment is to ask a loved one, in particular a spouse, are there things that the patient, he or she, did for themselves in the past that you have to do for them now? And if they say no, that the person can do everything they used to, that really calls in question the diagnosis. And if they say yes, then that lets you determine what the degree of functional impairment is. So if there's the one single biggest money question in diagnosing dementia, it would be that question given to someone who knows and lives with the patient as to whether there are things they have to do for the patient. So the rule outs, the things that you have to exclude, really are pretty common. And most of my work when I was at the VA for 12 years was about evaluating people with dementia and trying to tease out these other issues. These will be addressed in the other lectures, and I don't want to spend a ton of time, but I want to make sure that you know what they are. Delirium is the biggest one. Delirium deserves attention on its own. It's basically cognitive problems that start abruptly. The other name is acute brain failure. So it's an actual organ system failure. The most common cause in older adults is medications, but it can come on for other reasons, including medical illness. So if somebody has abrupt changes in mental status, you need to rule out delirium. Sleep apnea has very big effects on daytime cognition. So if you're not going through a natural sleep rhythm, you're not rested, and your brain doesn't work well, there's some patients we would see who appear to have pretty significant cognitive problems. And then when we found they had sleep apnea and started them on a CPAP, they got a lot better and wouldn't meet criteria at all. Vision and hearing problems are another very common finding in older adults. And if you're not seeing and hearing well, you're not encoding memories properly. So that too is something that if it's fixed, people's cognition often improves considerably. And then finally, mental health issues can greatly impact someone's brain functioning. And PTSD is a very significant cause of this, especially in veteran populations. Like this will come up later in the series too. But if you see someone who has PTSD and they're reporting cognitive difficulties, please make sure you consider that as one of the factors. And if you have particular questions about that, let me know, or Dr. Trichu, she and I have done work in this area. All right, so, great question from Lisa about vision and hearing loss. So if you look at the neurobiology of this, it's really interesting. Hearing, for instance, if you're not hearing something well, your immediate recall is okay. Like you can sort of have a conversation, especially if somebody talks louder, but the material doesn't get put into the medium-term memory. So you wouldn't think that somebody has a problem because they technically understood what you said, but unless the material is processed appropriately, which requires hearing it fully, then it doesn't get put into the other memory. So it's actually on a information processing level. And the same goes for vision. In particular, with vision loss, people tend to get disconnected and their brain takes over things. So you can have things like visual hallucinations or visual misrepresentation. So sensory issues, especially vision and hearing, really are closely tied to memory and coding. Great question. So let's focus now on what happens in Alzheimer's. As I mentioned, it's progressive. There's a slow, steady decline over a period of years. Usually the first thing, or one of the first things that goes, is insight. So the patient isn't really aware there's a problem. Usually takes people about 3 or so years of difficulties before they get medical attention for it. Like when I'd see people in the clinic, I'd ask them how long they had noticed problems, and the family would say, a couple of years ago, he started having mild lapses, but we just, wrote it off. And finally things got bad enough that we brought them in for care. So it's not over a period of months. Alzheimer's tends to involve little up and down, so every day is about the same. And the overall course from the time of presentation is about 8 to 10 years. Ultimately, it is a fatal condition because the brain functioning deteriorates so much, but most people die of other causes, and it makes sense because of the age at which they started. I don't want to belabor the findings in the different stages of Alzheimer's. Nobody is exactly the same in how they decline, but as I mentioned earlier, it really is based off of functional problems and your difficulty with day-to-day activities. So in the early stage, which lasts 2 to 3 years after people are diagnosed, they have some memory problems, some difficulty processing information, and mild problems with daily activities. In the moderate phase, it's a few years after that, people have difficulty with fluent speech, and they require at this stage help with some of the basic activities of daily living, not just the independent ones. And this is the stage generally when psychiatric symptoms appear. And this makes sense because it's a stage where the patient has enough awareness to know something is wrong, but they can't explain it. For instance, they're at home, they can't find their wallet. They're like, well, my wallet was here, somebody must have taken it. Somebody was here, my wallet's gone, therefore my wallet is gone. So it's different than what you might consider paranoia in a psychiatric illness. In fact, it's paranoia related to a misinterpretation of events. And then at the advanced stage, there are much more severe problems across all the different categories, and people may show real problems with controlling their behaviors. And then eventually there are motor symptoms, but usually those do not happen until quite late in the disease. It really is a problem with higher level functioning rather than basic bodily functioning. The reminder here is a nice saying from the Alzheimer's Association that I used to think was a little too cute, but I think it makes a lot of sense. That when you've seen one case of Alzheimer's, you've seen one case. There's some people whose personality is pretty much completely maintained as their cognition deteriorates. Other people used to be really friendly and pleasant, and then they get dementia and they start to get nasty. Other people, it's vice versa. Some people have very retained language abilities and lose the ability to do things. Other people lose their language but can carry out tasks. So because it is more of a global change, it's not uniformly global in your decline, and everybody's going to be a little bit different, and there's really no good way to predict exactly how the disease is going to progress, even though on a rough level, it is about 10 years between the time of diagnosis and death. So the question of risk for dementia is a very important one, and I'm sure you've seen the recent information about potential treatments for early dementia, and the Alzheimer's Association puts giant ads in the newspaper recommending more study of this. Unfortunately, the actual knowledge of the genetic basis of the disease still is not perfect at all. The early onset forms of dementia, which means before age 60, are much more likely to be genetic in character, and there to be family members who also had dementia. But most dementia is not early onset. Most of it comes on, as you saw from those graphs, in your 70s or 80s or later. And in this circumstance, it's known as more of a sporadic disease, and having a family member does not greatly increase your risk of Alzheimer's. It does increase your risk some, and there are some genes that are known to increase risk, but these are certainly not guarantees. So this isn't accepted by everybody, but after spending a lot of time working in this area, I'm pretty convinced that Alzheimer's is probably a result of kind of random events that happened and accumulated over time, rather than being the result of any one particular gene or maybe even a combination of genes. So ultimately, the reason you get Alzheimer's, I think, is just bad luck, plus a little bit of genetic basis. But this is important for reassuring family members. If you have Alzheimer's, it's not going to guarantee your kids are going to get it, or vice versa. And if you do get Alzheimer's, you shouldn't be blaming yourself for it. So then that question about whether the rates have changed over time. The rate of Alzheimer's has gone up considerably over time. And I mentioned that August Dieter, Alzheimer's first patient, was kind of a unicorn at those times. And then the question is why? Was it some kind of epidemic or some exposure to aluminum pots or power lines? And actually the reason is pretty easy. It's that we live longer, and the longer you live, the more likely you are to get dementia. So this top graph shows the life expectancy at birth in America over the last 100 years. It's gone steadily up. And if you look for the graph to see where most people die before age 65 or so, you're just going to get very few cases of dementia. And the bottom graph is just another reminder of the age-associated effect of dementia. And the difference in the groups, this is not a linear scale, it's like 20 times higher at age 85 than it is at age 65. So the simple reason people get more dementia now is related to life expectancy. So question from anonymous attendee about head injuries. Another great question. Yes, there is an association. Very briefly, the model of head injury is probably something called inflammaging, which is when you have a head injury, the inflammatory processes that happen end up accelerating the rate that your brain ages. So if you have multiple head injuries, your brain may be aging at 5 times the rate of somebody else, and therefore you accumulate more changes over time, and it's more likely these events would happen. There may be some other direct effects related to post-inflammatory changes. Great question. And then the comment from Lisa there about numbers being consistent, I agree. It can be reassuring. That's a really big question for people. I don't understand the question about blue zones. Maybe if you could clarify that, and I could.
You know, those areas in the world where people are particularly long-lived?
Oh, yeah. So same age effects. Yeah, you can see it in, those lines on the bottom are different countries. Ones I showed before, different countries. These don't include many, places outside of Europe, but really the age-adjusted rate of dementia is quite similar. There are some population trends, which I'll mention soon about prevention, but for the most part, the age-adjusted rate is about the same. Another great question. So then logically, you're going to say, this is a terrible problem. It happens often, comes on later in life. What could we do to prevent it? There's going to be more in the series about this. My short take, unfortunately, is really nothing. This is a big report that the NIH did. It's a little dated, but I haven't seen any good science recently that calls in question what it found. And you can see the finding here that there are no firm conclusions about the relationship between modifiable risk factors and Alzheimer's disease. There are certainly a lot of big studies suggesting that things like high blood pressure and high cholesterol are associated with higher rates of dementia, also head injury. But does that mean that if you prevented those, you would result in lower rates? Much harder to say. And more importantly, if you treat people's high blood pressure and hypertension, do you reduce the rates of dementia? And that simply has not panned out. So there may be ways of preventing Alzheimer's. I sure hope so. Unfortunately, we just don't know them right now. The way I kind of frame it in a backwards way is that we cannot currently make somebody get dementia if we wanted them to. If we took a person and we said, we're going to force you to have dementia, we cannot guarantee it in any good approach. Obviously, it would be wrong, but if you took them and made them obese and their blood sugars were off and they had high blood pressure and their lipids were bad, that would be like millions of patients in America who don't get dementia. So it really is a challenge when we don't fundamentally understand the cause of the problem. So Lisa, great question about why we don't consider it normal aging. You could argue theoretically that if a large number, if everybody gets dementia by the time they're 110, we should call it part of normal aging. But the prevalence rates really are quite a bit lower at earlier ages. And also, you do see these characteristic changes that signify some form of disease. So that's a very interesting semantic point, but it's certainly not considered to be something that everybody will experience. And hopefully we will understand enough about it someday to be able to prevent it consistently. I have a few examples just to bring this point home. These are questionable people in their own right, but clearly very accomplished. Margaret Thatcher is brilliant and highly successful. Ronald Reagan was an American president, as you know, very healthy guy, like model of health. Both of them got dementia. The Claude Shannon, who pretty much invented the theory behind modern computing. You can see how healthy he looked in his 70s. These were his pastimes that you see on the right. He was a healthy eater, didn't indulge in any bad habits, and he ended up getting dementia. Some of my patients that I would see, when they were in their 80s, seemed physiologically healthier than I am and were busy running marathons. And people who had been vegans their whole lives, and one guy lived on an organic farm and had never been exposed to chemicals and never drank or smoked a day in his life, and he got dementia. So unfortunately, the lifestyle factors that may protect against dementia on a large scale basis do not protect against dementia on a case-by-case basis. And it's important, if somebody gets dementia, that they not think that they caused themselves to have dementia because of any particular factor. All right, that's a little bit of a digression about prevention, and unfortunately, it's not really the best news. All right, so I'm going to turn now to another type of dementia, vascular. The key thing to remember here is that it's not strokes. Microvascular pathology, which is the characteristic finding, is changes in all or many of the small blood vessels in the brain. It's not having one area that gets clotted off or that bleeds. So it affects wide parts of the brain. It's not just localized, and clinically it really does look a lot like Alzheimer's disease. I have yet to understand why you can have vascular changes in your blood supply that then seem to cause a progressive neurodegenerative change. And then if you fix the cause of them, like if your blood pressure gets normal, if you stop smoking, if your lipids get back into normal range, your blood sugar is normal, you still have progression of the disease. So at some point, Alzheimer's and vascular dementia overlap, and we really don't understand why. So it's okay if you want to lump these together in your mind as being a similar condition. It's not like you need to keep Alzheimer's disease separate from vascular dementia. Unfortunately, also, there's no absolute way to define it on neuroimaging, even though there are more characteristic findings. Here on the left, what you see is somebody who had a large stroke. So that black area with the arrow pointing to it is effective a large stroke. On the right are the findings, periventricular white matter hyperintensities that you see in vascular dementia. And then on the bottom left is somebody who had a focal stroke that the white arrow points to. The interesting thing here, and obviously I can't prove this, is that the patient on the right with vascular dementia has many more problems globally than either of the other two patients. You can have a pretty big stroke and your brain is still plastic and can still rewire. But if you have a global change in your blood supply, your brain is not going to bounce back. Likewise, you can have rare, very small strokes like that one on the left that have huge effects on how you do. If you're ever interested in this finding, the movie or the book, The Diving Bell and the Butterfly, is fascinating, about a guy who had a very unusual stroke in his deep brain, and he lost the ability to move anything except one of his eyelids. And he ended up writing a book by blinking his eye when they would read him an alphabet. So anyways, you can have a very small stroke and have a huge effect, or you can have a big stroke and not have the biggest effect. But in vascular dementia, you get all those changes eventually, like happen in Alzheimer's. There was also an interesting study of nuns, where they looked at nuns during their lives and then their brains after they died, that suggests there really is a very strong association between vascular disease and Alzheimer's disease. That almost all the nuns who had clinical findings of dementia during their lives had vascular changes, whereas the ones who had just plaques and tangles were much less likely to do so. So again, it's okay to lump Alzheimer's and vascular disease. Well, so the question there about Alzheimer's being genetic, yeah, that's a great question, and potentially it's there, and we just haven't found the genes, but it really doesn't look like that for age-associated dementia. Some of the studies now are trying to find families of people with Alzheimer's, and in South America, there are some cohorts they're studying. But with those two, even though it looks a lot like Alzheimer's, I always kind of wonder if it really is the same thing as age-associated dementia. And if you found a drug that helped them, would it then help the people who didn't have the genes that they do? Great questions. And thank you, Lisa, for that explanation. All right, now let's turn to Lewy body, which is pretty common. You know, here on the inpatient psychiatry unit, probably about 10% of our patients have Lewy body dementia. This occurs throughout the brain. Alzheimer's is mainly on the outside parts and in certain lobes, but Lewy body is both in the outside and inside. And that means that you get additional types of symptoms. Lewy body has different findings than Alzheimer's. It's pretty common. I mentioned before, it's kind of hard to measure these exactly, and depending on your sample, they can be quite common. It usually happens with Alzheimer's rather than being alone. And the reason for the variation in rates is a lot of people get diagnosed with Alzheimer's rather than Lewy body, and then you don't even know about it until after they died. The characteristic finding is Parkinsonism. And these are if you know about Parkinson's disease, these are the characteristic findings. You get tremor that happens in Parkinson's. People's posture is stooped over. When they walk, it's kind of shuffling. When you pull on their arm, you get this kind of cogwheel effect. And then there's a characteristic facial appearance known as masked faces, where the patient does not show much facial expression. So they may be telling you like, I'm really happy, but they're just not showing it. Interestingly, families often use these exact terms when they're talking about their loved one, and they'll say, oh yeah, he's stooped over and he shuffles along, and it's like his face doesn't show any emotion. So it's they're hard to miss when they happen, but unfortunately they often don't happen much early on. And there are plenty of patients that I assume have Alzheimer's disease, and then as we wait it out, we find that they have much more Parkinsonism. The other very unusual finding in Lewy body disease is visual hallucinations. Visual hallucinations are not all that common in psychiatry. And so if you see someone who does have well-formed visual hallucinations, you want to think of Lewy body disease. This condition also tends to wax and wane more. I mentioned that Alzheimer's is pretty much the same every day. Lewy bodies tends to be worse day to day, or sometimes every other day or so. Things will get bad. And oftentimes you can have intact memory until relatively late. So somebody may have Parkinsonism and visual hallucinations, but their cognition is intact, and that still represents Lewy body disease. And then the most important practical reason for identifying it is that these patients are very sensitive in a bad way to antipsychotic drugs. So those drugs like Haldol, Zyprexa, Risperdal, Seroquel, those are dopamine blockers. And in Lewy body disease and Parkinson's disease, you don't have enough dopamine to begin with. So in general, those classes of medications make symptoms worse in Lewy body disease. And sometimes that's how we first start looking into the diagnosis of Lewy body, because somebody is treated with an antipsychotic and then has a negative reaction to it. All right, that Lewy body is a fascinating topic. I don't know how much more it's covered in the series, but if you see somebody with dementia who has these other findings, it really is worth looking into that. Also, from a caregiver perspective, it tends to be a much rockier road. Most of the patients with Lewy bodies, there's some challenges, in part, I think, because things come and go and you get these unusual symptoms. In Alzheimer's, a lot of times, if somebody gets taken care of, basically they'll do all right. But with Lewy body, you want to anticipate that it may be more of a challenge for the caregiver. All right, real quickly on frontotemporal dementia. This is pretty rare. You may never see it, but it's an interesting finding. This is basically where the frontal lobes of the brain start to atrophy. You can usually see it on a CAT scan or MRI. You get the changes that you'd expect when your frontal lobes are not working, such as not having appropriate social boundaries, disinhibition, problems with complex thought, but your memory initially is pretty much intact. And then eventually the injury to the brain or atrophy to the brain progresses back and you get more effects on memory and basic activities. This one tends to be much more familial and to come on earlier in life than Alzheimer's or vascular disease. Here's a nice picture of it. On the left side of the brain, that's basically a normal occipital lobe. And then on the right side of the slide is the frontal lobe, and you can see how much that has deteriorated. So it starts more in the front and then eventually progresses back. So unusual finding, and it's good to know about if you even if you never see a case. Finally, there's all these things that are or used to be called reversible dementias that are actually medical problems that have cognitive side effects to them. So any of these, if you have a bad case of it, can cause you to get confused and maybe to have functional problems. And you wouldn't want to say that somebody who has a case of heavy metal poisoning actually has dementia. But really, they're kind of more for historical interest than practical, because nowadays we can test for labs pretty easily, and you can barely set foot in a hospital without having the labs done that would rule out a lot of these conditions. The picture on the bottom right is just purely for kicks. The thing in the middle is known as the face of the giant panda sign. So it looks kind of like a panda bear, and that's a accumulation of copper in the brain in Wilson's disease. So I don't need to know that, but if you're into pandas, there's something else fun to report about them. All right, I want to move away from the types of dementia and talk about how we work up dementia. Fortunately, it's not that complicated. It's really based on history and ruling out other causes. The history is the most important part, and especially getting history from somebody else besides the patient, because they're probably not going to tell you when they started getting memory problems or how bad they are. If somebody fits well with the diagnosis, if it's been a slow, steady decline for 3 years and they've got some memory problems and some functional problems and nothing else, you don't need to do a bunch of extra workup. If something is funny, if they can't move their left arm, and their labs are off, then you would do more workup. But really the workup doesn't have to be complicated, and there's just some basic labs that we check. And even though almost everybody does get a CAT scan of their brain or an MRI as part of a workup, it really doesn't add that much value, and it's not routinely indicated if there's no other complications. So you don't have to do anything really fancy. You do want to do some testing. I'll just show you two examples. Now, most everybody uses the MOCA, although copyright issues have complicated that. The mini mental state exam, MMSE, is a 30-point scale. The important thing to remember about it is that it is normed for age and education. So you can see on the right top, that's education level and score. People who have no formal education can really get a very low score on it and still be at 50%. If you have a lot of education, you really should be getting a high score. And then age also, as people advance in age, their score drops some. So the change that you can see there, for instance, in age, the scores are dropping, 1 point maybe every 4 or 5 years on average. If you have dementia, the drop is about 3 points per year. And the math makes sense here nicely, because if you have a 30-point scale and the disease takes about 10 years before you die, that is 3 points per year. So just remember, in dementia, if you're testing for it using one of these scales, you'll expect a pretty consistent decline, and it's about 3 points every year. A more simple approach to trying to define cognitive status is known as the mini-cog. This was developed at the University of Washington by Sue Borson. Despite its simplicity, it's still almost as good as a longer test for picking out people who have problems. The first part is remembering 3 words. You ask them to remember 3 words, and then they repeat those back until they get them. If they can't do that, they probably have a real problem, but most people can repeat 3 words. You don't get points for that. The next part is a clock drawing test, where the person draws a clock and puts the hands on. You tell them to make it be, 11:10 or whatever time you pick. And then that gets scored as 2 points for a good clock, 0 points for a problematic clock. The clocks, except for A, don't get any points. And then you ask them to remember the 3 items, and you get 1 point per item. So if you get all 3 items and the clock done, you get 5 points, or the worst possible would be 0. And for this assessment, a 0 to 2 is considered a problem and you got to do more. 4 to 5, you're probably okay, and 3, you want to look into it more. But technically, that would be not a sign of dementia. So this is actually, if you work with older patients, it's worth memorizing. It would take you 30 seconds to memorize. And you can pull it out of your back pocket and use it to assess somebody's cognition without having to download a MOCA or some other structured test. And also you save yourself time. So mini-cog, well worth knowing about. All right, I want to address this topic of screening. I use the word screen for the mini-cog. That's wrong. I shouldn't call it a screen. It's a assessment test, simple assessment test. And you hear about this frequently in the news. This article came out a couple of years ago. This is the actual text of the blurb in the paper. It says that there's this blood test that can predict with 90% accuracy whether somebody's going to develop Alzheimer's or cognitive decline. And it was validated. So the question about blood tests before was a great lead into this. So you think, hey, this sounds pretty good. 90%, that's gonna really help pick the people who have dementia. So, but I want to break it down. And if you ever come across a screening test, I encourage you to use an approach like this to figure out what really is at stake, because you can be greatly misled by screening tests. So let's say this test is 90% accurate, which means that if you do have dementia, you'll get a positive test 9 out of 10 times. And if you don't have dementia, you'll get a negative test 9 out of 10 times. So far, so good. But what does that translate into? Let's take a hypothetical group of 1,000 people, older adults, and based on those rates I showed you, about 4% of them would have dementia, or 40 people actually have dementia, and 960 don't. So you do this test, and of the 40 who have dementia, 36 of them get a positive test. That's great. So 4 people are told, oops, kids screaming out there. 4 are told wrongly that they don't have dementia. And then of the 960 remaining, 96 of them receive a positive test. So of 1,000 people, you're getting 96% who are told, hey, you have dementia, even though they don't. And then what do you do with that? You're told you have dementia. Do you redo the test and then say, well, the second test was negative, but it's really just the same test? There's no gold standard to follow up on. So you're giving people a lot of bad news. Put another way is in terms of positive and negative predictive value. So if you have a negative test, your likelihood of actually having dementia is very low. So that's great. It's useful for ruling out dementia. But if you have a positive test, your likelihood of not having dementia is 73%. So if you look at all the numbers, you realize that this test is 73% false positive for the people who are given a positive test if you don't have dementia. So you've just taken 2/3 of the people who you say are positive and told them they have dementia when they actually don't. So that clearly is a problem. And even though the test looks good on paper, when you run the numbers, you realize it's probably not going to help anybody in the world to be told they have dementia when really they don't. So even though we have some blood tests that look promising, because of this challenge with false positivity, routine screening is not recommended by the main bodies like the US Preventative Services Task Force and the VA. So the better approach to finding dementia is to wait until people present with problems or what are known as warning signs. And as soon as they come in with a problem, then you do a workup and you can do some other tests. But on a population level, it does not seem to help to go looking to see if everybody has dementia. So quick question there from Zach. Great question about slowing the progression. Unfortunately, we don't have any predictive strong ways of doing this. For the reversible dementias, as I mentioned, if you can fix the problem, like if you've got hypothyroidism and it's profound and you start taking thyroid medication, your cognitive problems will improve. So for the things that are cognitive problems as a result of medical problem, usually if you fix the medical problem, it goes away. But once somebody starts this progressive neurodegenerative decline, it really, we do not have ways now of stopping the progression or in fact, even slowing it down considerably. That is a challenge. And you will get into this much more in the talk about rational prescribing in dementia, and they'll go over some of the data about that. So we only have a few minutes now, and great question, Zach. Thanks for that. Few minutes left to talk about the theme from the beginning that I really think is much more important than plaques or tangles or screening. And that will be the topic of much of this series, and that I hope that at the end of it you will come away with a better sense of the person in dementia. And to do this, the key questions are, why is it a problem? And we talked about that before. It's a problem for socio-cultural reasons, and because in our fragmented society with small nuclear families, older people are mainly expected to take care of themselves. And as you are no longer able to satisfy your role and you can't do things for yourself, somebody else has to do it for you. That really is the crux of it. And then how can we help people with dementia? And obviously this is a huge problem, but the general boiled down take home, I would say, for how to help people with dementia most is to care for the caregiver. This is going to come up in the caregiving talk, but really the biggest burden in dementia is not on the patient themselves, it's on the person who's taking care of them, and in particular the spouse, if there's not a lot of other support. So when you talk to somebody who has dementia, please focus on their larger context, the world they live in, the people who are helping them out, and what's expected there, and what the emotional needs are of those other people. If you look only at the patient and the patient's brain, you're going to be missing most of the important issues. And my brief rundown on how to do this is, to listen to their perspectives. You have to ask the caregiver, do you get time for yourself? How are you? How are you doing emotionally with this? Don't make assumptions about what may or may not be difficult. Some people love being caregivers, and they'll tell you, this is what I was born for. I love taking care of my spouse, and I'll do it, and I keep him home no matter what. they're not common, but doesn't mean that your approach to caregiving would match up with theirs. You do want, insofar as you can, to make sure that people with caregiving responsibilities are not depressed, and if they are, to get them appropriate referral and treatment. And then to think about the big picture, the well-being of not just the patient, but the patient's spouse. And a lot of times this involves giving permission to the caregiver to get more help. And the way you can frame it is to say that if the caregiver gets more help, and they don't try to do it all on their own, they can be more emotionally present for their loved one, and everybody will be happier. It's a ton of work to do hands-on care. And if you're doing it all the time, it can be very frustrating and challenging. You're better off having somebody else do it, even though there's a lot of reluctance to do that. Also to recommend the associations that are listed. Alzheimer's Association is a great group. It's not just Alzheimer's, it's any form of dementia. There's a ton of supports there. The county and city have a ton of resources also, especially in our area, but every state has an area agency on aging that helps to address dementia care, and states usually have dementia plans that help specify what those services are. And then finally, if people can afford it, a private social worker can be enormously beneficial in helping to connect people to the type of care that they would need. Oh, thank you, Lisa. Private social worker, usually called a care manager. So this is a more formal process. So yeah, if you're referring somebody, I agree, private social worker probably isn't the right word for it, even if it is an accurate description. So care manager. Unfortunately, that's mainly for people who have plenty of money. So finally, I want to make a brief comment about agitation, because I don't think it gets addressed that much in the other lectures. My recommendation for this is simply to make sure you know why somebody's agitated before giving them a pill to deal with it. When I talk to the psychiatry residents, I'll oftentimes run a case by them and say, this patient's acting out at night, they're very agitated, what do you do? And the residents will generally start arguing about whether they should give them Haldol or Zyprexa or some other drug. And then I have to stop and say, whoa, let's figure out why this patient is agitated before you figure out what to do with them. And surprisingly, psychiatrists, even though we deal with behavioral problems, we often don't learn about what the source of agitation is. And it was a social worker after I was in practice for a few years who provided this scheme, and it's been extremely helpful to me in thinking about why my patients become agitated. And I try to share it because it really is a good approach. So somebody put pain there, absolutely. So this is a rough framework. Delirium, you got to make sure that somebody's brain is not offline. If they have delirium, it's acute brain failure and they're just not firing properly. That's pretty easy to sort out usually. Unmet needs are huge. So pain is a big one. If somebody has a soiled diaper, or if they're too hot or too cold, or if they're lonely, the natural human response is to get agitated. I mean, if you're thinking about where you are right now, if you're in the room you're in, somebody locks the door, turns the heat up to 90, and you can't have anything to drink, or you can't go to the bathroom, you're going to get agitated at some point. So if you can identify what the needs are and fix them, that oftentimes addresses agitation. We sometimes use pain medications in nonverbal patients who seem agitated and they get considerably better. Conditioning is another funny one. That's the response that you have based on your reaction. There's classical conditioning like Pavlov and ringing the bell and the dog salivating, and then there's operant conditioning where people who get rewarded for something do it again. Both of those apply in dementia. Even if you're not remembering something, you respond through conditioning. So if you're in a nursing home and suddenly, you get ignored. But if you hit somebody once in a while, you get a very nice person sitting next to you, you will be more likely to hit people continually. Great comments in the chat box about trauma history. Thanks for pointing that out. And I think that relates to this final point, that if you could see the world from the patient's perspective, you might be just as agitated. So if you're sitting there and somebody comes at you and tries to take your clothes off you, what are you going to do? I mean, you're going to fight back because they're trying to take your clothes off. The patient with dementia doesn't understand that it's the staff people who are trying to give them a bath in a loving way. And if somebody has a trauma history, their interpretation of the event will likewise be colored as more likely to be a threat. So if somebody has PTSD, they're always on the lookout anyways, and so they may be especially likely to lash out and try to protect themselves. So over time, the more I see of dementia, the more I appreciate that if I could get in the patient's mind, I would think that what they're doing is the right thing to do. And finally, a quick note, I know this will come up again too, but antipsychotic medications, which are very often used, have a black box warning for dementia. They about double the risk of dying from dementia. And so if you see antipsychotics being used, please just keep that in mind. And you might tip the people prescribing them off that they're dealing with something that's potentially risky. All right. Any additional questions after the talk, please just email me. Oops, that phone number is totally wrong. That's my old VA number. Don't call the phone number. But the email is me. And I look forward to hearing from you, and otherwise, thanks for joining. So we can have some questions. So the question about anesthesia and dementia, great question. Another very interesting line of research. Again, it's hard to sort out exact cause and effect. There are definitely correlations that have been measured, like people who underwent general anesthesia are more likely to develop dementia. It is hard to rule out other factors that may be confounding that, and especially their health condition, because to undergo general anesthesia, you need to have something else going on that's the reason for that. General anesthesia also is associated with higher risk of delirium. So you're tipping your brain into an unhealthy state, and it could be that state of delirium is partially responsible for causing downstream changes in the same way as head injury. So great question about anesthesia. If you know of particular findings in that area, I'd love to see them because I've only seen general reports. So great question about the Vietnam War. Agent Orange, very highly politicized topic. Kind of the party line about Agent Orange is that it's not a known risk factor for dementia per se. And it's hard to tease out epidemiologically because of all the other various factors you have to control for. It wasn't like Agent Orange exposure was completely random across the population. There was almost entirely men who were exposed to Agent Orange, for instance. Also, the experience we had at the VA was around the effects of PTSD on cognition. And Dr. Trichu, who's going to be talking in the series, has done a lot of great work in this area, showing that people who were in Vietnam, especially later in life, present with cognitive problems. But when we do a full workup, it's not dementia. It's more related to PTSD. And these patients oftentimes have trouble focusing, and they can't be present in the here and now. And so they interpret that as being a form of cognitive impairment. So there may be other factors related to cognition in people who were exposed to Agent Orange, who also likely are at high risk for PTSD. So great question. And there again, if anybody knows anything cutting edge, I'd love to see it. So great question about sundowning. So this is a kind of a topic that would merit attention in and of itself. The basic idea is that people get worse later in the day. And that has some plausibility. So in general, it probably shouldn't be called a syndrome because it's more of a worsening or exacerbation with the diurnal rhythm. And when it has been studied scientifically, a lot of people call in question whether it really should be characterized as a common finding in Alzheimer's or other forms of dementia. And the reason is that, again, as with all these other causation things, that when you factor out other issues, it's hard to demonstrate that people consistently or on a broad level have a time of day in the evening when they get worse. A large part of it appears to relate to the caregiver's level of distress. So if you're a caregiver and you've been up since 5:30 with a patient who is agitated at times, occasionally, and wants to follow you around, and you never get a break, you're going to get more frustrated later in the day. And as I mentioned, caring for the caregiver is key, and if the caregiver is not doing well, that can escalate and lead the patient not to do as well either. When sundowning is studied in more controlled environments, like inpatient units, it often is associated not with time of day, but with shift change. So you have a whole new set of people coming into your life. That only naturally would result in the patient being more distressed. And so, the studies where they looked at if shift change is always at 4 o'clock, when people get worse at 4, if you shifted if you move the time of the shift earlier or later, does the agitation get worse? And it appears that it probably does. So all this isn't to say that there is no such thing as sundowning, because patients certainly manifest it, but I would not think of it as being a routine or predictable finding in Alzheimer's or other dementia. And in fact, as you might expect, that the best approach is to look at each patient and think about when they get agitated, why they get agitated, and what factors you can control in order to limit their agitation, including exposing them to more routine or comforting stimuli, and also caring for the caregiver. All right, have I missed any of the questions, Barb?
You've been masterful. It's pretty impressive. So
well, these are great questions. I really appreciate all the thoughts and questions during the talk.
So I see the question about to fill in the evaluation, and I did put the link in the chat box for the evaluation. Just a second, and I'll put the link in the chat box for how you access all of the other information, which is actually the course page. You can register, you can just log in and access the various resources, such as the handouts, the recordings, that kind of thing. It all kind of links from that page, which is a little bit new. We used to put all kinds of links in. The link for the evaluation is also on that same page, but I've also, just for your convenience, put the direct link to the evaluation survey in the chat as well. And Dr. Thielke, thank you so much. This is always such a wonderful refresher, very practical, and we really appreciate it. And I will see the rest of you next week then, or at least ECU, and have a great week. Thank you so much, Dr. Thielke.
Thank you all. Good to see you. Okay, bye-bye.